The yellow fever virus belongs to the flavivirus genus, a group of arboviruses, as do the dengue, Japanese encephalitis, and Zika viruses. This high-stability virus has only one serotype and is transmitted by Aedes, Haemogogus, and Sabethes female mosquitoes from a primary reservoir of non-human primates and from human to human. Once infected, mosquitoes remain infectious for life and are the ones transmitting the virus to humans through biting, mostly during the daytime. The clinical spectrum of yellow fever goes from asymptomatic infection to potentially fatal hemorrhagic disease. 55% of yellow fever virus infections are asymptomatic. For the others, after an incubation period of 3 to 6 days, or in some cases up to 9 days, patients experience abrupt onset of fever, chills, malaise, headache, lower back pain, generalized myalgia, and nausea, as well as frequent loss of appetite, dizziness, congestion of the conjunctivae and face, and bradycardia. This viremic phase is the period of infection or acute phase, which lasts 3 to 4 days. For about 12% of those infected, after a brief period of remission of up to 24 hours when the virus is cleared from circulation, a toxic phase begins, which manifests itself with high fever, vomiting, abdominal pain, prostration, and dehydration. The virus also affects the liver, which usually leads to jaundice, a yellow coloration of the skin that gave its name to the virus and can lead to severe hemorrhagic manifestations, including bleeding of the eyes and nose, as well as gastrointestinal bleeding known as black vomit. Acute renal failure as a result of kidney damage may also occur. Half of the patients who enter this toxic phase die within 7 to 10 days after the beginning of this phase. When surviving, lifelong immunity is acquired. However, all populations aren't affected in the same way. For local populations in endemic areas, the overall fatality rate is about 5%, rising to 20 to 30% once jaundice and severe symptoms occur. Whereas for non-immune travelers and migrants, and during epidemics in areas that have low levels of yellow fever activity, the case fatality rate can exceed 50%. To date, no drug has demonstrated specific benefit, and management of the yellow fever virus is supportive, based on symptoms and the organ systems involved. Salicylates should be avoided because of the risk of gastrointestinal bleeding and platelet suppression. Yellow fever can only be prevented through yellow fever immunization and personal protection against mosquito bites.